generous. I mean, you have more material, better, more mature, and anyway, it's fantastic. I'm more into it. I'll have more. I'll wait for give you a complete feedback to be more into it. But I'm there. But I had a question that doesn't seem to be in your material. Um, Tongue diagnostic. I, it's very simple the way we look at it in TCM, blah blah blah, and I liked it because it's clear. But I'm following my own tongue, and it's changing so much in color, in coding. So the whole reading of my own tongue changes during the day. So I was wondering if you use it in your style, and if you have uh, what does it? I mean, what do you get out of it, basically?
Oh boy. So okay, so I actually don't use the tongue much. I personally don't use the tongue much. I will use it if I'm giving people herbs, which I personally don't do a lot of. And the reason I don't do a lot of is because um, people, well, some people love taking herbs, granted, but well, because I was trained to do raw herbs and I'm not good at, at patent medicines and stuff, no one wants to really cook herbs forever. So I will do something, I will give people herbs, for say 2 weeks to just get a strong shift. And at that point I will look at their tongue. Generally speaking, I don't even look at people's tongues. It's kind of shocking to many people. I do look at my own tongue, and sometimes the other thing is I've noticed looking at people's tongues over Zoom, every so often I've tried that, because of herbs, because of the period that we're in, is very difficult. It's a total, you can't really tell what the hell's going on Zoom, in my experience. Maybe my computer isn't good enough or something. Um, my own tongue also changes a lot, but the tongue, this is why I don't use the tongue. Well, there's actually two main reasons why I don't use the tongue. For one thing, it's not something I can change immediately on the table. So yes, it changes over the day, although there's, generally speaking, there's a person's tongue tends to be a certain way for periods of, say, weeks or months. I'm not sure. Like I said, I don't look at it enough. Um, but it's not something that you can needle a point and literally see a change in the tongue. Okay, at least not that I've ever seen. There may be people who are real experts at this and really can do something like this. But so the thing is, I'm looking for, my concept of diagnosis is not the same as when Western doctors talk about the diagnosis, which is a relatively static thing. It, it's a description of a condition that you supposedly have. I'm only interested in that description as long as I have a way to address it. It's a tool for me to find points or to find herbs or to find a treatment. So if a tongue can be very useful in giving you a diagnosis, especially in the TCM world. I don't have that equivalent. I'm not that interested in, are you hot, are you cold, are you damp? Which are the three major things that the tongue shows. Congestion, blood state, any kind of status, I guess, to some extent. But it's really, you're primarily looking at excess and deficiency, hot and cold, and then some sort of dampness pathogen type thing. These are, as if I remember correctly, that's what the big things that jump at you from the tongue. Those are, I'm always looking for the deficiency, period. I don't care about the excess is kind of like the excess is there because there's a deficiency. So I'm always looking for a way to find out what is the weakness behind why there is quote unquote an excess or a stagnation or something that would be considered an excess. So the whole concept that's behind tongue diagnosis doesn't apply to my method of thinking as well, to my methods of diagnosis. I'm not that interested in dampness. Unlike schools in TCM, that dampness is one of the big evils because it's hard to move through.
Hmm.
dampness slows you down, therefore it's such a huge deal. Um, I don't have any of that um, understanding or the, I mean, I can claim that I have the understanding theoretically, but I'm not using that understanding as my tools. And the biggest thing is I'm using anything that I'm diagnosing, I want to be able to show myself that it's correct or incorrect through the tool. So, now with herbs, it's different because you can't, I mean, the only way that I know people can muscle test an herb and say, oh yes, and you can criticize it or not, but herbs in general, you're giving it according to a, just like in a Western modality, you giving them herbs according to your diagnosis, and you're going to be proven right or wrong after a certain amount of time when they've ingested the herbs. But with acupuncture, I generally want to see results on the table. Now, the results may not be so clear. The results may be not as direct. For example, somebody comes for menstrual cramps, okay, but they're not on their period. They don't have menstrual cramps. I'm not going to be able to take away the menstrual cramps. What I'm assuming is if I'm clearing the body's findings, I'm also influencing the menstrual cramps, especially if they have findings that are very clearly gynecological by nature. But it's an assumption. It may not be true. Go
Yeah,
ahead, you have a question.
but the treatment is part of the diagnostic, so it
For
makes a
me,
lot of sense. Yes.
but for most medical professionals, diagnosis is not the diagnosis dictates the treatment
Hmm.
usually. If you have a treatment, by the way, sometimes we have. I mean, how often do you get a diagnosis where they say, well, you have Jacob's Lactozati syndrome? Okay, I don't know who Jakob Zatzitz probably is, but he made up a syndrome, and no one knows a cure for it. There's still not a cure for it. It's very common.
Yes, it
It's not,
is.
so it's diagnosis is a world of its own. And by the way, in TCM, they do something a little bit similar. The
Hmm.
diagnosis is supposed to dictate the treatment. What I'm saying is, okay, that's nice. Now, you have to go backwards and say, if the treatment didn't work if your diagnosis dictated the treatment and the treatment didn't work, what does it mean? You can say the treatment it didn't follow the diagnosis. Well, that becomes very dogmatic at that point. My diagnosis was correct, the treatment was wrong. Or you say the treatment did not prove the diagnosis or didn't match it enough, fine, but it didn't prove the line of thinking between the, and for me, that's the part that matters. I'm not that interested in staying with one diagnosis constantly.
Hmm.
you know so it's a question of point of view. And as you know, especially in the Western world, um what we call allopathic medicine, there are people whose specialty is diagnosis. There are people who don't treat, they only diagnose. Radiologists will be a prime example of by profession, that's literally what they do. They never see the patient. They see a picture, and they pronounce a judgment. But a lot of other people, they're experts. That's their specialty. They're not interested in treating. They're interested. They are being sent people specifically for diagnosis and only for that. They're not going to follow up in treatment. And you actually see it even in the hierarchy, quote unquote. Often doctors will pronounce treatment ideas, but the implementers are often nurses. You see that in hospitals. The doctors are a very small amount of time there. I mean, it's just the system. But a nurse generally is not allowed to diagnose for the most part.
Hmm. And the law is clear. Anyway, here the law is
Oh,
extremely clear.
okay.
You cannot even use the words. Here we cannot use the word diagnostic. What I found very interesting is when there is a diagnostic, and when the patient, when there's a diagnostic of a terminal or a disease that cannot be cured, because the
Mhm.
diagnostic goes to that step of being sure of what it is, and the person does cure because it happens. Uh, then they change the diagnostic.
Of course.
That's extremely interesting as a mental model. Yeah, in their situation, that there's no way of, instead of lowering the strength of the diagnostic itself, of the act of diagnostic, by saying no, 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 this is uh, can be cured sometimes, and keeping a door open for that, the diagnostic is changed. But the person went through the whole, like, cancer, went through it all. Anyway, that yeah,
Yeah, well,
it's an
you can.
extreme formalism, extreme. It's an absolute decision rule. There's no way out. Yeah.
Yeah, I mean, but that's you have to accept that in an institution like a hospital or large clinic, you need that authoritative and hierarchical system is very important. It's what keeps that system. The system can't
Yes.
be kept together without it. So in a way, I think it's great. I mean, if they say to you, you have blah blah blah, and your survival rate is no more than 6 months, and if then, here you are, and suddenly, and now they're saying, oh, well, and all the tumors are gone and blah, blah. Great, the diagnosis has changed. That's perfectly fine. I mean, it, I know it doesn't appeal so much. It doesn't sound like it's flexible, but in a way it is flexible. Your diagnosis used to be this. For whatever reason, we don't know why, but for whatever reason, you
Right.
no longer show the same parameters. We're happy to change your diagnosis. Well, cool.
Yeah.
I mean, there's nothing wrong with that.
Yeah. It's an
You know,
illustration of how it comes like that. That's how it's done. Yes, and we can we know it's predictable, totally predictable. Yeah. Do you work on a lifestyle? Because I listen to many demonstrations,
mhm,
and then you have the students. So you it's a special setting, uh,
mhm.
and I see that you confirm, of course, through abdominal findings, and you confirm through the symptoms that are present. Um, but I did not. I'm wondering, typically, frequency of treatment, or uh, how much it works by itself afterwards, and how much you can do, because um, in the you don't do other things. You do these treatments, and so you put back you give the signal so that the functioning goes back to physiological functioning, but you don't do symptomatic, don't do much of symptomatic afterwards in your treatment. You
Depending. It
dependent.
depends. Not everyone's symptoms disappear or get affected strongly enough just because you treated the so-called constitution. I mean, this is a huge, big argument especially in the Japanese modalities, but in the Chinese as well. There's this whole thing about roots and branches, and the superior practitioner treats the root, never treats the branches. God forbid. It's like, if you're a gardener, you trim the branches. You don't just fertilize the roots. The branches and the roots depend on each other. The leaves fall down in the fall and they nourish the earth. They fertilize the roots. You can't say, I only treat the root. If you only treat the branch, I mean, if you're going to treat one or the other, generally speaking, you're better treating the root. If you're that um, dogmatic and I can only treat one thing, better treat the root. Fine, I get that. But you get some Japanese people, and if you, God forbid, you ask that the patient comes for neck pain, and I've literally seen this in classes of like big Japanese names, and the patient's on the table. It's usually not a patient from outside. It's usually, someone from the class. And they do whatever they were going to demonstrate this root treatment of blah, 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 blah pattern or whatever. And they did that. And then my first thing is like, okay, and how the hell is your neck pain? I love that they treated your liver and you blah, blah, and you blah, blah, and you blah, blah. That's very cool. But you actually came for neck pain. So it's very important to know how you, and some of these people, if you actually ask the person who's on the table how the neck is, they get upset. We don't treat the symptom. We only treat the root. And this is very common. People who do pulse diagnosis. The moment the pulse is to their liking, they're like done. I'm treating the abdomen. So, okay, most people come to me, at least, don't come to clear their abdomen. They don't come to get a better pulse. They do come to get a better life, but they have defined what their better life is to a large extent by a symptom. My first responsibility is to clear the symptom, but to do it in the most effective way. If I only clear this now, if they came yesterday, they went, I don't know, they did some sort of, they had some sort of accident, okay, and the shoulder hurts. I can get away maybe with just treating the shoulder. Just pick up your best trick for shoulder or knee or whatever, good. But even cases like this, where it just happened, where it's so-called acute, you can't tell if it's just the acute injury or the body itself has remnants of other things that are holding this current injury. So I would rather always treat the full picture. Then if the injury itself, the actual symptom, hasn't been affected, then use tricks for the symptom. There's nothing wrong with it. I absolutely will use it. Now, the other thing to consider is sometimes what you think is a symptom. Now, we're talking about long-term situations. What started as a symptom has become a root.
Hmm.
You can't say it's a symptom. Sometimes, like, well, I fell on whatever and, there was this trauma. This has become the root of other things that are building on top of it. Every injury you've ever had has the potential of becoming one of the roots. So I don't distinguish so much between, um, treating symptoms, treating the root, because they're correlated. They're always, not always, but for the most part, they're always going to come together. But I'm always interested, can I clear the abdomen in the most effective way? Meaning, can I find the deepest roots and clear those, see what it does, but then check the symptoms. Because if the symptom didn't clear, then I can tell the patient forever how, oh, you're so lucky you came to me and look what a beautiful abdomen you have now. Aren't you happy? And they're like, what the fuck? Who cares? That's not what I came for. I came for my shoulder, neck, knee, blah, 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 blah. That's the only thing that matters to them. So I would say it's not, one has to treat both. Now, in terms of lifestyle, lifestyle is a very difficult phenomenon because people don't like changing their lifestyle. And we as practitioners have a lot of ideas about lifestyle that may not be correct. So I always have to keep in mind, like, let's just take the famous argument about coffee. There are practitioners who, I know practitioners who, they will not take a patient if the patient drinks coffee. They have to stop drinking coffee first. It's like, okay, I'm glad you can have enough patients that way, and I'm glad people are cooperating. That's lovely. But the reality is that most people now, I happen to be someone who doesn't drink coffee, so it's extremely unfair for me to say to a patient, don't drink coffee. It's like, I don't know what it means. It's like, I don't know what kind of sacrifice it requires. So it's not relevant I'm not saying it's not relevant to the patient's life. So you have to be very careful about offering advice and see how much openness you're hitting, how much resistance you're hitting. Does the patient, whether resistant or not, do they want to engage? People can want to engage even though they're resistant. And I have to work with the patient where they're at. And there's a few big things in lifestyle, and all of them are incredibly difficult. So the first thing is diet. And I can't tell you how many patients I've basically lost once we went into diet. They just don't want to, they can't deal with it, and then they feel pressured, and then they disappear. So they're gone. So what good did I do them? I mean, yeah, and some of them, years later, they'll tell me I have a number of patients who like every few years they call me and tell me how I told them, yeah, I told them many years ago, and now they've discovered it's true. And I'm like, I don't remember I told you anything, but whatever. If you want to make me into the person who discovered it, that's fine. What am I going to say? No. But generally speaking, it's not. It's one has to really tread very carefully because, and I can't tell you how many people I say to them, tell me about your diet. I eat very well. Is like 95% of people say that. I
Mhm.
don't, it doesn't mean they do it, but that's what they say. And then they say, okay, so a typical day, tell me about breakfast, lunch, dinner, and everything in between. And then suddenly you're discovering all sorts of things that, oh, you call that oh, I did, yeah, I didn't count that. I did. We're all convincing ourselves, me included, that we're eating relatively well. Because who wants to say I eat like crap? It's just not what we like to say. So, and we want to convince ourselves. So that's the first one. So that's extremely difficult to discuss and implement. The other thing is things like sleep and exercise. Okay, and which relates to that the other factor, which is busyness. Those are the sort of actually, well, let's call it busyness, exercise, and sleep and relaxation. Those, I would say, those three things: diet, um, activity, and resting are, and quality of these things, of course, are the three big lifestyle issues. Those are extremely hard to get people to give up, to make changes on. So you mention them, you do what you can, but I am not the kind of practitioner who insists on do this or else. And I'm making sure, they came to me for acupuncture. I'm trying to make the acupuncture the main item on the menu. Okay? And yes, you can. Of course, there'll be times when I will say, oh, yeah, you really need to do this in order to make this have a better chance of succeeding. you know, I was just talking to someone this a few days ago about, and she said she is very overweight, and and all these doctors are saying to her, well, you have to lose weight, and every doctor says to her, well, the reason you have pain, you have mild arthritis, not enough to justify this, and you have this, and it's mild and not enough to justify, and at the end of the day, she's in pain. And then to say to the patient, you need to lose weight, well, it's definitely true, but it's not helpful, because in the meantime, when people are in pain, it's hard for them to exercise. It's hard for them to lose weight. Many of them can exercise and never lose weight. I mean, they still need help in losing weight. You still need to treat them. Can I affect the metabolism to some extent and help them lose the weight? If this is really what I'm thinking, it's all about the weight. But often it's about lose weight, come back. And it's often one of those situations. So I think that as a practitioner, I'm interested in doing whatever I can, and I don't care what the name is, to get the person towards a better situation. Okay? And lifestyle will be one of them, but lifestyle is ultimately dependent on them. I can only offer advice. And always this advice is experimental. In other words, they're experimenting with my advice, and they're going to be the determining factor. Just like the point will decide if the diagnosis is correct. When they, whatever, eat soybeans or not soybeans or whatever it is that the advice is, it's their body that's going to say yes or no to it, not my idea of it. So, and yeah, in class it's a lot harder because, it's like you get into, I definitely don't want to teach people. As a teacher, I'm teaching acupuncture. I don't want to teach people lifestyle advice because it is so individual to different practitioners. It depends very much on your philosophy. I'm a, I'm a vegetarian, for example. Most TCM practitioners are not vegetarians and are very strong believers in bone broth and all sorts of things. And I'm like, okay, I mean, I can't recommend this to patients. It doesn't fit who I am. I'm not saying it's wrong, or, I'm just saying it doesn't. So I don't want to go and impose neither on patients nor on students what lifestyle is, what the correct lifestyle is. Does that make sense? So that's why, I concentrate on the mechanics of acupuncture, because that's really what I'm there for. And to a large extent, that's largely true in the treatment room as well.
Yes, it's interesting because it was a question, but I didn't ask. You do that a lot.
Oh, I don't know. I've heard the question. I know. I've seen the questions many times. I mean, at some point you kind of know what the largest subject is. Maybe it's. I'm not psychic. So, anything else?
I was listening to a heart consultant recently enough who said a cup of coffee per day was really beneficial for heart functioning. So
I would
it's
say
hard to know.
yeah. Quite honestly, I would tend to agree. Coffee is a dilator, so it increases circulation. I mean, I think the problem with coffee is that when you have to, when people have, usually I have some patients who actually ask me about that. They're anticipating my coffee problem. Like, I have a problem with the people who have 6 to 8 cups a day. The person who has 1 cup of coffee, okay, is it an addiction and you have to wake up with a cup of coffee in the morning? Okay, so what? We all look. I brush my teeth in the morning. Is that, no one is going to dare tell me it's an addiction. It's like it's expected that I should brush my teeth. Otherwise it's not appropriate, quote unquote. So it's like, 1 cup of coffee or even 2, big deal. There are so many addictions out there in the world, and coffee is a dilator, and it does pump you up. I also, yes, is it true that some people, they, with coffee, they can actually have a bowel movement? Without coffee, they can't. Is it a problem? Yeah, because they've gotten a dependency. But, so I think 1 cup, honestly, is not going to make a big difference, even 2. Now the other thing is, what people don't recognize is all the stuff they put in their coffee. Coffee is not just coffee. I mean, are they putting sugar? Are they putting any other sweeteners? What kind of milk are they putting in there? In certain cases, it makes it. And so it's all a matter of, like, what else are they doing? But yeah, and by the way, people with asthma, for example, coffee can work wonders for them. Because it's a dilator. It's like getting a shot of peppermint or something. So yeah, everything has to. There's a middle way for everything. If at all, I mean, there has to be a middle way, because the patient is going to find their own middle way. And if you can't negotiate a middle way with them, you're going to be very. There are people who will do the most extreme things for them, because they're very determined, but many people won't. And I see Camille has a comment.
You can always tell when I unmute myself, don't you?
I happen to be able to tell, yes.
Yes,
Sure.
yes. Well, my comment is, I don't know how cardiology is practiced in Ireland, but here they're very free with beta blockers, and beta blockers really weaken the heart in the long term. And so the cardiologist ends up seeing people with increasingly weakened hearts. And they don't have our herbal paradigm of strengthening the heart with foods and astragalus and things like that. So when they see a person with a very weak heart and caffeine comes along and gets that heart excited and beating, they're quite pleased, because they don't have any other way.
Yeah. That makes sense. Well, I guess we could we can put a new patent out of aconite and astragalus and make it into grind it up to powder and put some coffee in it. And sell it
Well,
for
I
lots of
often
money.
treat people with things like Zhen Wu Tong, and then I add in astragalus. That's a very standard thing. And then when I studied cardiology in China, the big one was Huangqi Shengmai San,
Yeah, makes sense.
which is a little more limited because a lot of people, as their heart gets weaker and weaker from beta blockers, their blood pressure actually goes up as their heart tries to compensate. So the Ren Shen isn't always good, but
You need the Huangqi.
but I mean, at least we have choices, and they don't understand cardiology. I think the way it's practiced in this country is criminal. No, seriously,
No,
I
no,
really
I'm
do.
laughing because I there's a person I know a cardiologist who does acupuncture, so I'm just like wondering what he might say about it.
Well, I would welcome his comments. I
I will
always will
ask,
take
actually.
feedback, and he may be a wonderful exception.
Yeah, no, I know, I hear you.
I'm sure
I
he
do.
is. If he's bothered to study acupuncture,
Right,
I'm sure he is an
exactly.
exception. Yeah. So anyway, that's my comment. I'm done.
Yeah. Fair. No, yeah, it's true. I think the thing is because of there's so much in circulation that's not that's cardiac but depends on the kidneys and the adrenals,
Mhm.
and that's why coffee can make it, can make a difference.
So on another note,
Yeah.
can you remind us of the cardiac back treatment?
Okay. Well, it depends on what you call a back treatment. So
Or
in
or your cardiac treatment in general, then I won't qualify it.
Oh boy, okay. it okay, so if you're just looking at is if it's cardiac unrelated to anything else, as if there's just a cardiac system, which it very rarely is, okay, so because it's usually tied in with circulatory. So usually with cardiac, you're going to treat this, you're going to end up treating spleen pericardium very often. In the same way that, for example, in anxiety, you tend to treat spleen pericardium. There's a somewhat decent chance that you'll treat liver. Remember that liver is mother of wood is mother of fire. So what's happening with the liver is important. And also don't forget that liver, number one, liver is a big sponge, so it affects circulation. And number two, liver has to do with clotting factors. And quality of blood. So you can't just, so there's a really good chance that you're going to need to treat the liver. So you're going to treat liver, spleen, pericardium anyway, and in all likelihood. And then what you have now, originally Ren4 was for cardiac was supposed to be for when the pulse is big. But quite honestly, I find that it works in general. And of course, if the person has rapid pulse and you do not want to do Ren4, I will use on the side gallbladder 27. Okay, level with Ren4, but go all the way to the side instead. And then for example, tachycardia. Now, don't forget that before you treat the heart, there's two main things you need to, you cannot treat the heart when there's two conditions present. Okay, one is edema. Okay, so you need to move the water, otherwise you're making the heart pump against edema.
Mm-hmm.
Okay, which is you definitely don't want to do. So you're going to weaken the heart at that point. So before I do, if they have edema, I do spleen 3, spleen 7, spleen 11 to move the water. And then while those needles are in, I can start treating the heart. Okay. The other condition, very similar, although almost like opposite, is when someone's pulse is very, very, very weak. Okay. I can't treat the heart because I'm making the heart pump against the vacuum. So there isn't enough resistance there. So that has to be, addressed first, pump the blood up a little bit. So that will be either as spleen 6, pericardium 6, or spleen 6, pericardium 4, or spleen 9, some sort of spleen combination just to get the pulse a little bit stronger. And if you want to do it almost superficially, you can do direct moxa on REN12. Okay, that tends to pick up the pulse a little. And then you can, you know, so whatever you're doing for the heart, which up to now I've talked about REN4, don't do until you've made sure that the edema is being moved to some extent. And I don't mean move it for 3 months, get rid of the edema. I mean, for 2, you know, just spend a moment, move the edema, or strengthen the pulse a little bit first, then move on. And then you have, for example, for tachycardia, you have under the second toe on the left. For pulse that has intermittencies, that's skipping, gallbladder 39, sometimes gallbladder 4 or 5. These are all points that have the character Schwann hanging. Okay, you have a pulse that's hanging. So that's the idea. Now on the back, now your reflexes on the front are going to be the left kidney line on the chest, pericardium 1, but don't take it once and out of the nipple. Take it, you know, just like you take stomach 18 at the root of the breast, take pericardium 1 at the side root of the breast. And stomach 18 can be a pericardium cardiac reflex, and just below lung 1, spleen 20 can be a cardiac reflex on the left, all on the left. On the back, you have small intestine 11, as well as the inner border of the scapula, which is the outer bladder line. So UB 42, 43, 44 area. And what I can do is I can actually check points in the front while I'm palpating left small intestine 11. From, you know, even though they're laying face up, I can get my hand under there and check points. On the back, your treatment is, you can call it bladder, outside, bladder 27, small intestine, you know, just like small intestine mu, you do small intestine Shu, but basically what you're looking for is this sacroiliac ligaments. So whether you call it bladder 27, bladder 26, whether you call it bladder 53, it doesn't matter. It's all the sacroiliac ligaments. Then the other thing I do is I check bladder 60, the fire point of the bladder channel. And if there's no pain, I can needle bladder 60 upwards and check it against small intestine 11. If it does have pain on it, I'll do bladder 66 and 67, the metal water. And again, I do it with the idea of, does it affect the cardiac reflexes? Then this is the difference between cardiac and lungs versus all the other reflexes. With both heart and lungs, you have to at the end of the treatment, the actual quote unquote treatment is actually needle moxa the reflex. So in the case of the lungs, it's say bladder 13, bladder 42, you know, the area between the scapula. In the case of cardiac, it's the same area, usually more lateral, more towards the inner border of the scapula, and small intestine 11. So you want a needle and direct moxa on it. You actually want to strengthen that tissue directly. Okay, so whereas, you know, for example, with spleen, you know, if you have some digestive issue, you don't go in the abdomen where the intestine is and do moxa on it. You know, that's not in this style. We don't do that. So though that's the big difference. So you're using the reflexes to the nth degree that you can, and then move on. Now, the other thing I forgot to mention is that with cardiac issues, there's often a component of the autonomic nervous system, because the heart itself is controlled by a pacemaker. The heart itself is highly relying on an autonomic nervous function, on an actual nerve bundle. So, addressing the autonomic nervous system, releasing the SCM, looking at blood pressure, et cetera, these are all important also for cardiac as a quote unquote preamble. Now, very often when you've done your preambles, you end up not needing to use. You kind of go, I don't have anything to test REN4 against. That's fine. I'll still do it. Does that answer the question?
Yes, thank you.
You're welcome. All right. Anything else?
That was superb, Avi. Thank you.
No problem. You're welcome. Anything else? Last opportunity for the year.
Oh my, yes, it is the last of the year. Mary Jo?
Just as you were speaking there, Abby, I'm wondering, like, how closely related would the pericardium reflex be, or how, like, effect on the heart as well?
I don't really know that I have a pericardium reflex. So I'm not sure
I mean,
if
I think pericardium 8, for instance.
okay, yes, yeah, that's why I thought that might. So the pericardium 8 reflex is often related more to not necessarily to the heart itself, but often would be related to the to circulation in general and or the autonomic nervous system. Okay, so so yes, it has an effect. So like I said before, most heart conditions you will probably be looking at spleen pericardium combination and possibly a liver, and then an autonomic nervous system, then check edema and notice that edema is spleen, and then check for not enough blood in the pulse, that the pulse is not full enough, which is basically spleen pericardium also, once again. Okay, so you kind of it's almost like you're always coming back to spleen pericardium plus liver, then treat the heart. But as far as not many people with cardiac issues will not show pericardium 8 at all. It's much more typical for blood pressure type people, autonomic nervous type people, and usually one side will show and the other won't. It's very, very rare that both pericardium 8s will show. It's also very rare, by the way, that heart 8 shows. Okay, it does exist. It's pretty rare. Now, I'm not a cardiologist, so I don't, it's like if I were, it'll be interesting to see if like suddenly, everybody I see has a heart 8 on the left side. It's conceivable, but I'm not so sure that it's I don't know, because I don't see it's not a it's not enough of a specialty for me to be able to say, oh yeah, from what I see, heart 8 does not appear to be a very common finding. So pericardium 8 is, but it's not limited, or it's not necessarily specific to cardiac in any, I can't say I've noticed that it's specific to cardiac. Now, if you have diode rings, any cardiac, I do the middle finger diode ring, and on the left, I do the little finger. So in that case, the little finger on the left has to get the red. Okay, which means the middle finger, because the little finger got the red diode ring, the middle finger will get the green. Okay, so then on the right side, the middle finger will get the red diode ring. Now, then if I'm treating liver, I may have a problem, because if I want to do it with diode rings, now I want to use the thumb, and it's dictated to me now that this thumb needs to be green, which means it's a liver excess. And that's often not the case. It's often liver deficiency with cardiacs. Remember, it's the mother. If the mother is weak, the wood is weak, then fire is weak because its mother was weak. So I may have to sort of manipulate. I may not use all 4 rings. If I really want to use the thumb with a ring, I may give up one of the middle fingers, because I'm dictated that the little finger on the left is red If now I'm dictated that their right thumb is red also, I can't use both middle fingers. Okay, sorry, that was kind of almost rude, but I can only use one middle finger because the colors are it's gonna clash on one side if I use both of them. Because I have red and red. I have red on the left little finger, and I have red on the right thumb for the liver deficiency. And I'm left with green on both sides of the pericardium finger. So I can only use one side. And I will usually choose the left side if that was going to be the case. This is one of the few cases where I really need, if I'm going to use dyed rings, I need to check everything in advance. You know, in cardiac situations, because of the dictation of which, you know, what color it has to be. Because for cardiac, the left little finger has to be red, or so I was told. So, you know.
Yes. Thank you.
You're welcome. Anything else? Patrick, you had a question before, it looked like.
The typical, okay, I'm surprised. I'm not doubting it, but I'm trying to understand better. Within a treatment, you can send many signals when you, let's say, you generate blood, and then you're able to pass to the next stage in the same treatment. So after 2 minutes or whatever. But I'm wondering, after treatment, typically, because in DCM, I know frequency is necessary, and sometimes frequency is twice a week, and it can even be more than that. But so I know the notion, and I've experienced the notion of over treatment. But sometimes over treatment is because it's not the right treatment more than, but we have adjustment for over treatment with this style. I'm just trying to see, like I'm asking in advance, but I'll experience it probably. But what to expect as far as patient, not flow, but patient. Like, you know, from one treatment to the next,
Okay.
They come back with the same kind of the same findings. Is that fine?
Yes,
is it
yes,
a negotiation, a dance, or and timing? What we let the client leave, and we don't tell them when to come back, or it's better to have a second.
That's up to you. Okay, let me try and address that. So I personally treat once a week at the beginning. I generally suggest to people, I mean, when they're, well, especially if you're talking about cardiac, etc. I mean, when you talk about someone who comes for a chronic problem, I suggest them to do, you know, basically I tell them try 3 or 4 treatments once a week. If you see absolutely nothing moving, forget it. Just don't bother coming back after 4. You know, it's just not worth it. You know, now there are people who will insist on coming anyway because they believe it's worth it, and suddenly after 10 treatments something starts to move. But how many people have that kind of patience to do that? So it all depends on your personality, your ability to sell things, etc., etc. I'm not good at that. You know, that's not my forte to tell people how to work and stuff. So so I try and get people to come once a week for the first 3 or 4 weeks. And I also, the other thing is, on the first treatment, I explain to them very clearly, I don't charge differently for first treatment or other treatments. And one of the reasons, there are more reasons than one, but one of the reasons is because you can never tell what's going to happen at the second treatment. The second treatment might actually be more complicated and may take more time than the first. Yes, you've gathered the information on the first one, but what happens if you went the wrong path on the first treatment? And the patient comes back the second treatment, and it's not about the findings. Some people's findings will get less and less. Some people's findings, it will take weeks before it starts to, the abdomen changes. That's not the biggest sign. The biggest sign is, how are they feeling? That's much more important to me. They need to feel, you know, I want them to feel something. So if they're feeling nothing after a week, and it's a symptom you would they should have felt something, like they're coming for migraines and I get a migraine 3 times a week, and oh yeah, I've gotten 3 migraines and they're just as bad as then there's a good chance I'm not touching it. And then I have to say, okay, I created a strategy according to the medical history and according to the abdomen, and it may not have been wrong, but it wasn't complete. So the second treatment, I have to come up with more. Now, how much can we do in a treatment? Okay, if you're hitting more than 3 ideas, you should look at it. When you hit 5 ideas, you're treating 5 different routes. Your chances of being successful are not good, because no one has just one route and that's it, and everything comes from that one route. That's a little absurd. But when you start having multiple routes, and they're all routes, now notice I'm not saying you can treat 3 routes and then add some things for the symptoms. But if I'm saying, like, let's talk about the cardiac stuff from, because that's supply. If I say I need to treat the edema, and I need to generate some blood, and I need to treat the autonomic nervous system, and I need to treat the bladder, and by the way, they have a thyroid problem, and I want to treat that because yes, it can affect the heart, of course. And then I'm treating cardiac. Now I'm on 6 different ideas. Now I can say that some of them are actually serving the cardiac, but I'm just there's just too much going on. The body's getting too many messages. So there's a good chance that the body's not going to be able to assimilate. So then I have to say, what's the priority? So I may say to myself, now, unfortunately, edema is not something edema in a way you can say is not a root. It's a manifestation, but it's a manifestation that's disturbing. Okay, it's not going to let me do much. And it's going to not just stop me doing the cardiac, it's going to stop me from doing everything else, because as long as there's edema, the signals are slow in the body. Okay, everything is like sluggish. So I have to start prioritizing, and maybe, yeah, not every patient you can go against all the ideas that you have. In the larger majority of patients, you can prioritize in a way that it wouldn't make a difference. So you can say, according to the medical history, and I can even see it in the abdomen present in them right now, they have 7 different things that need to be treated. Usually I can reduce it to 2 or 3. And if I treat those 2 or 3, the other 4 or 5 are affected very strongly and either disappear or fade to a large extent. I should not have to go against 7 different routes. When I see myself doing that, or when I see myself doing whatever number of routes I did, and then I'm starting to chase after more symptoms, more and more and more symptoms, like, because the symptoms were not affected by my so-called route, the route was useless. Forget the route. The route was the wrong route for this person. It sounded good in theory, but it didn't prove itself. So, I mean, if a route doesn't affect a symptom, that's okay. But if a route doesn't affect any of the symptoms at all, and now I'm trying to chase symptoms and doing tricks for different symptoms, what was the point of the route? The route, let me find another route. Okay, that may be less elegant, maybe less interesting, maybe whatever it is, but it's going to affect the symptoms. It may even not reduce the abdomen as well as my original route. That can happen, but it does affect the symptoms. The abdomen is just one method. Suppose somebody has pressure pain on a certain place in the abdomen and it didn't go away. So what? No big deal. It's a sign for me that the pressure pain is getting better, but it doesn't mean it's not like Moses came down with a tablets and it said, eliminate pressure pain on right liver 13. It's like, I don't think so. So it's okay if it stays there, as long as what matters are the symptoms at the end of the day. The abdomen is a way to get at better symptoms, at a better person, let's call it. But it's not for me to evaluate. So when you're getting too many roots, so too many is above 3. Don't get too dogmatic. There are people where you're not going to have a choice. But when you're seeing yourself treating more than 3 main things, and then you're adding a few little things that are what I call insurance, I'm adding insurance. But when it's not insurance, when it's like the main dish, it's like a meal. 3 main dishes is a lot of food. How are you going to digest that? So when you see yourself do that, you have to really question yourself and then say to yourself, okay, can I let go of one? And not because I'm letting go because I'm being, I'm letting go because can I find something that actually is going to affect it? Can I think better? What it tells me is I'm spreading my thinking and I'm not finding the right stuff. It tells me and it happens. I just couldn't figure out this patient. And that's why second time, maybe I will. So does that answer kind of like the flow idea of how it gets
Very well.
managed?
Yes, thank
Good.
you.
You're welcome. All right, well, Happy New Year.
You, Evie.
And
everybody else.
Sorry?
I said Happy New Year to you and everybody else. Camille.
Yes, thank you. And hopefully 2021 will be a better year with more opportunities for questions, with more opportunities for patients. We won't be locked down away from patients. So
thank you so much, Avi, for all that you give to us. And I wish you a wonderful year.
Thank you. Thank you for coming every week and making this available, making it possible to do. So appreciate it.
Thank you, Evie.
All right, enjoy.
Happy New Year, everyone.
Bye.
Bye.